Welcome to Diabetes Day by Day, the American Diabetes Association's official podcast. In today's episode, we're going to talk about a question that many people with diabetes ask, and that is, what diabetes medicine is best for me? Choosing the right medicine isn't a one-size-fits-all thing. Each person's health, their lifestyle, and their personal goals matter. In this episode, we're going to break down the different types of diabetes medicines. We're going to explore approaches to individualized decision-making about therapy using the latest American Diabetes Association standards of care as our guide. And we're going to share practical tips to help you make informed decisions alongside your healthcare team. Remember, our overriding goal with Diabetes Day by Day is always empowering you with knowledge so that you can go to your healthcare practitioner and have a discussion about what's best for you. Whether you're newly diagnosed or looking to optimize your current treatment, this conversation will help you understand your options and empower you to take control of your diabetes management. I'm Dr. Neil Skolnik, Professor of Family and Community Medicine in the Sidney Kimmel Medical College of Thomas Jefferson University, and joining me is my co-host.
Hi, I'm Dr. Sara Wettergreen. I'm an associate professor at the University of Colorado Skaggs School of Pharmacy, and I practice as an ambulatory care clinical pharmacist.
Let's start by talking about differences in medicine selection based on the type of diabetes someone might have. Before we dive in, though, I want to let everyone know that as we have this discussion, we're going to be talking about general categories of medicines. And if we talk about particular medicines, we're going to be using what is called the generic name of the medicine. That is the not brand name of the medicine. When you look at your medicine bottles, you see often two different names. When you look up medicines, two different names. One is a brand name, one is what's called a generic name. Because there are so many different diabetes medicines, and we don't want to be in any way perceived as favoring one medicine over another, we're going to talk about categories of medicines, and when we mention individual medicines, there'll be generic names. But we're going to try to include in the program notes that you can see when you open the podcast, a list of, if not all, most of the important, common diabetes medicines with the brand name and then next to it, the generic name. So if you have a question about something you're on, something on TV, an advertisement in a magazine, or just want to know what is what, that will be available in your program notes. Now, let's dive in. Remember, there are two types of diabetes. There's type 1 diabetes and there's type 2 diabetes, and they're actually very different from one another. We'll go into depth about this at another time, but for now, suffice it to say that type 1 diabetes is the type of diabetes where the main thing going on is that the pancreas does not make enough insulin. Therefore, in type 1 diabetes, insulin is the primary, usually the only treatment, and is certainly the essential treatment. Sara, do you want to say a few things about the different types of insulin and different ways that insulin can be used?
Absolutely. And you're exactly right, Neil. We know insulin is essential in people who are living with type 1 diabetes. But that doesn't mean if you're living with type 1 diabetes that you don't have options. If you're a frequent listener, you've heard from some of our guests who have talked about their selection of therapy and how they've gone between maybe different choices within the realm of insulin. But you still have choices. Someone might be on a more traditional basal bolus regimen with multiple injections of insulin a day. If you're looking for more cost-effective options, there are some with some NPH or regular insulins or combined insulins to limit your number of injections per day. And if you're looking at cost, sometimes those are a little bit more cost-effective as well. And on the other spectrum, we have our more expensive but are more high-tech options like automated insulin delivery systems or insulin pumps. So even within the realm of type 1 diabetes, there are certainly choices. For today's discussion, we're really going to be focused more on the different medication classes used primarily in type 2 diabetes, but wanted to highlight that if you're living with type 1 diabetes, you still have options.
Excellent. So, Sara, let's dive in and talk about some of the choices with regard to type 2 diabetes. And I've been practicing now over 35 years. And I got to tell you, it is amazing to me how much things have changed over that period of time. So I want to go back a little bit. And we base our approach on the American Diabetes Association standards of care, and to give our listeners a sense of how that has changed. If we go back 20, 25 years ago, the algorithms were actually fairly straightforward. Pretty much everyone began with metformin. It's a great medicine. It helps the liver process blood sugar. It makes the body more sensitive to insulin. And that was where everyone started. There was good evidence that it worked. And then after a while, it would stop working, and you'd add what's called a sulfonylurea. And then, that was pretty much it, and then insulin. Along the way, there came a class of medicines called the TZDs, and there were a couple of different ones, and those would also get used as well. But then, a big change, really not that long ago, in 2015, a lot of studies came out that taught us how to make a more individualized approach to selection. And those studies came from large trials called the cardiovascular outcome trials, where we found out, and this is one of the most exciting things to have happened in diabetes since the discovery of insulin. We found out that some medicines work particularly good for people with underlying heart disease, with either coronary disease or other vascular disease, or people who have types of heart failure or pre-heart failure. Some medicines work great in people who might have even earliest stages of kidney disease, which is a big, important thing to pay attention to. And some medicines help us lose weight. We've talked about that before on this podcast. So we have an opportunity to individualize our choice of medicines in a way that we never used to. Do you want to take us on that first step, Sara, of individualizing medications?
Yes, and what I like to think about, Neil, is just the context for those cardiovascular outcome studies, which were almost a springboard for future studies and other conditions. But looking back, there was a medication, rosiglitazone, which is no longer available, that had cardiovascular risks. And so then it was determined by the FDA that diabetes medications should undergo cardiovascular safety studies. For the first piece of these studies and the initial trials, they were just looking to see, are these medications safe? But what was found out is not only are they safe, but they actually were improving outcomes for people with cardiovascular disease or high risk for cardiovascular disease. So it's just so interesting to think about how that science has evolved over time.
It is. And we live in an age where there's a lot of, we can say it, mistrust of science. You and I have had the opportunity to see the amazing things that science can bring us. And I always think that we ought to approach everything we do with some degree of both trust and skepticism, that we ought to be looking critically at things, but also be willing to take advantage of advances as they happened. And without any doubt, these cardiovascular outcome trials have led to fantastic advances. So let's think about some individual scenarios where that might lead us. So Sara, let's say someone comes in and they're in their mid-50s. Perhaps they also have some high blood pressure. Maybe they have some high cholesterol as well, and that would put them at some elevated cardiovascular risk. Let's even add to this that they have a history a few years ago of having had a coronary stent put in, which prevented them from having a heart attack. So that's a good thing. So they come in and now their A1C's been up above 6.5, above 7 on repeat, and it's time for them to start medicines. How would you help them think through what's a good medicine to start?
That's such an important frame for it, Neil, and I really like how you phrase that because it's about presenting options, in my opinion. And we know that's where the evidence is in this shared decision-making process. I, as a pharmacist, don't want to say this is the one and only medication that would work for this person. It's really talking through the numerous options available and thinking about pros and cons. What are this person's individual goals? What are their other medical conditions? Do they have certain concerns about side effects? What is their insurance like? And so I would be thinking about all of those pieces. When thinking about selecting a medication therapy, one that would come to mind, front of mind for me in this scenario would be a GLP-1 receptor agonist. So thinking of someone who has other cardiovascular conditions, I would maybe be looking at their weight as well to see if they might be interested in losing weight, if that's within their goals or something that might be medically advised. So to frame that medication as an option. So when thinking about the GLP-1 receptor agonist medication for this person, there are a few things that I would be asking them about. So another fun thing I like to think about with GLP-1s is where did they come from? Fun fact about GLP-1s, they actually were studied in the mid-1990s by two different scientists who discovered from the saliva of a lizard called the Gila monster that this saliva stimulated insulin production in the body. So when people talk about all the buzz about GLP-1s and these being new medicines, they were initially discovered as a compound in the mid-1990s, and then the first medications in the class came out about 20 years ago in 2005. So although you can't go a day without hearing about a GLP-1 receptor agonist, it seems, they have been around for a while. So I think providing some of that historical context can help people know that we have historical context for these medications and their use as well. This class of medications works to lower the blood sugar by helping this to stimulate the pancreas to make more insulin in response to higher glucose. And another way that it primarily works is to slow the digestion of food through the stomach. So by slowing that digestion, people can feel full longer, may not eat as much at certain meals, and so that's why we often see weight loss associated with this class of medications as well. So if we're thinking about different patient populations, I'd be thinking about someone with type 2 diabetes who has maybe another condition that might guide us toward a medication in this class, and we'll get more into that evidence, and also someone who might be looking at weight loss as a goal. What about you, Neil?
That's so important. And what you point out is also so important, that it's often not one thing that drives the decision. You mentioned a range of things. And often people have high risk for cardiovascular disease and excess weight. And the GLP-1s, when you put those two things together, really are very powerful medicines. We've talked about them a lot in the context of weight loss, and they're also incredibly powerful glucose-lowering agents. We also, of course, mention when we think about cardiovascular outcomes, the class of medicines called the SGLT2s. Also, in that part of the algorithm that the ADA has for people with cardiovascular disease. Again, people come with lots of different aspects. We all have different aspects. And the SGLT2s, while they help you lose a few pounds of weight, that levels off pretty quickly, and it's not usually more than a few pounds. So the ability to address obesity at the same time as cardiovascular risk leans one perhaps toward a GLP-1, but the SGLT2s are high up there as well, and we'll talk in a minute about their effect on the outcomes. What's amazing, though, as I say that, and as people are listening, what you begin to realize is how much things have changed. So it wasn't long ago that everyone got metformin and then got a sulfonylurea. And now, whether we talk about the person we just described, or even let's say that person didn't have a stent and was in their 50s with high blood pressure and cholesterol and excess weight or obesity, they still might go to eat a GLP-1 first before metformin or sulfonylurea. And again, though, as you so wisely alluded to, we are lucky to live in an age of choice, because if someone's insurance doesn't pay for some of these newer medicines, and they can be very expensive, we are fortunate to still have things like metformin that is on the $4 a month list at many pharmacies. Sarah?
Yes, that's exactly right. I think the pros of the number of medications we have available is that there's always an element of choice, whether it's based on your preferences, whether it's based on your family history, whether it's based on cost or wanting to avoid particular side effects such as hypoglycemia or weight gain, or if you're pursuing desirable side effects like weight loss. Each medication has its pros and cons. So it's such an important opportunity to have a conversation about that.
Sarah, let me throw another case example of someone coming in, let's say 62 years old, history of high blood pressure and obesity, and their nurse practitioner recently did blood work, including blood work that only recently has been recommended as routine, something called an NT-Pro BNP, baby Norma Princess, BNP. And that was drawn because of a new recommendation that we should be checking for the earliest signs of beginning of heart failure, even in people with type 2 diabetes who aren't short of breath yet or not having problems yet, because early heart failure is very common in people with diabetes. Almost a quarter of people with diabetes after they've had it for a while can see the beginning stages, and it's important to catch early. We might talk about that on a future episode. But they have a slightly elevated BNP, and their doctor ordered an echocardiogram, and it turns out they have the little bit of evidence of what is called heart failure with preserved ejection fraction, so as not to scare our listeners, because that's a scary term. People can do very well with it, but that is the name of it. What would you think about with that person? And let's say they've been on metformin for a few years, and let's even say that their sugars are pretty well controlled with an A1C of 6.9. Anything you would do for that individual?
Neil, that's a great thought. And there's so many factors there to keep in mind. The two classes of medications I would really be thinking in that scenario about are the SGLT2 inhibitors with proven benefit with people with heart failure, as well as GLP-1 receptor agonists with proven benefit in this population. So when thinking about that particular scenario, I might be weighing a few different factors to talk about with this individual. So if you're someone who might feel similar to this person, this is a good thing to think about. So thinking about someone who is relatively close to their A1C target, their individualized target, or if they're already at that target, but they have this condition of heart failure, then I might be leaning a little bit more toward that SGLT2 inhibitor class. The way that class works is they help an individual to excrete extra glucose in the urine. So through this process, we see lots of different effects that happen in the body. It's pretty interesting, just even beyond the glucose lowering itself. But one of the benefits identified is a decreased risk related to heart failure complications like hospitalization or exacerbations. So thinking about that, I would be thinking about SGLT2 inhibitors are very effective. They have this benefit in individuals with heart failure. But in terms of A1C lowering, it might be a little bit less robust compared to something with very high efficacy in terms of A1C lowering, like a GLP-1 receptor agonist. So that might be one consideration to think about. However, you also mentioned that this person has obesity, and so we would probably also talk about if that's more of a goal to think about, maybe we would prefer the GLP-1 receptor agonist in that situation to support goals of weight loss if that's within their individual plan.
It's such a good point, and it raises that point that we often don't even have to say, is it one medicine or the other, but many people might be on more than one medicine, each achieving different goals for their individualized needs. To round our discussion of the SGLT2s and the GLP-1s, let's say someone had gone to the physician assistant that they are seeing, and that person checked routine kidney studies, including a urine, looking for what is called a urine albumin to creatinine ratio, and they were what is called spilling protein. They had high levels of albumin in the urine, which we know can be an early sign of kidney decline in people with diabetes. What would that lead you to? What two classes of medicines might you think of then?
I was going to say, I feel like a broken record, Neil, but it's the same too. SGLT2 inhibitor and a GLP-1 receptor agonist. So I think that just goes to highlight the point that these medications you hear about so often in commercials for, and you might hear about them just from friends and colleagues because they are used and there's been identified benefits in so many different patient populations, whether it's cardiovascular disease, heart failure, chronic kidney disease, some forms of liver disease. We're finding benefits with use of very similar medications across the board. And so that's why these names are so popular. But we also know that there can be barriers to medications in both of those classes. Some of the barriers we've mentioned so far, which could be cost, that can certainly be a barrier. And so we would think about ways to get medications in those classes at lower cost as possible. I'd put my pharmacist hat on to do that and help patients with that. But also thinking about individual factors. So, for example, for the GLP-1 receptor agonist class, there is a less common form of thyroid cancer that if a person has a personal or family history of that rare form of thyroid cancer, then a GLP-1 wouldn't be right for them. And so that's why it's so important to work closely with your medical team to talk about what all the options are and some of the details about those medications so you get an idea of, is it right for me based on all of your individual factors and preferences.
That's so important, Sarah, because we haven't spent a lot of time talking about side effects, because that wasn't the goal of our discussion today. Our goal was how to pick a medicine. But part of picking the medicine is going over the potential side effects with the doctor or PA or nurse practitioner or pharmacist that's helping you sort through what is going on. Because, again, we make these decisions based on lots of factors, but hopefully the information that we're giving also it lets everyone listening be able to have a better back and forth conversation. Now, we started off talking about metformin and the sulfons and the TZDs. Where do they fit in now, Sarah?
That's a great point, Neil. So thinking about, well, metformin, first of all, it still can be considered first line in many individuals. So if you have type 2 diabetes without any of these other conditions that we've talked about so far, metformin is a highly effective medication. It is very cost effective. That might still be the first line for many individuals. On metformin, don't be thinking you're on the wrong medication for you necessarily. It's still the right medication for many people.
Yeah.
But beyond that, and thinking about sulfonylureas and the TZDs, which really the one we use now is the name pioglitazone, these medications have a little bit more risk in terms of side effect profile. And so that's why we don't see them used as often. But that doesn't mean everyone has those side effects that occur. There are many people who take medications and have no side effects. So thinking about that in terms of sulfonylureas, these are medications that help the body to release more insulin. Compared to other medications that do that, like GLP-1s, it's not only in response to higher glucose. So a downside of that class is that they can risk the blood sugar going too low. So that's one reason that we don't see them used as often, but in many people that does not happen often or at all. And so in those individuals, it's a great option. With the pioglitazone or TZD option, that medication helps improve the body's sensitivity to insulin. And so with that, it does have some benefits in that it does not risk dropping the blood sugar too low. But in less common cases, it does have a side effect of weight gain, fluid retention, or swelling. And so when we think about all those things, it would not be an ideal medication for someone who has heart failure. And so we just try to weigh the pros and cons of these medications that might be more affordable, but figuring out if it is appropriate based on the individual's patient case and their other medical conditions.
Said. And Sarah, that brings us back to good old insulin.
That's right.
When do you, for people with type 2 diabetes, when do you see insulin most commonly used?
Yeah, and that's a great caveat, Neil, because we started off this conversation by saying insulin, mainstay of therapy for everyone who has type 1 diabetes. But for type 2 diabetes, we don't see it used as often because we have other medications that work well for type 2 diabetes as well. When thinking about starting insulin, I might be thinking about someone who either there's some other reason that they're not producing insulin well. There's many different reasons that could be beyond the scope of our discussion today. But I also would be thinking about someone who has a higher baseline A1. So if you think about the effectiveness of each of these medications, I'd say the most A1C decrease you typically see in each of these individual classes is somewhere around 1%. So GLP-1 receptor agonists are very effective. We're still only seeing an A1C decrease on average in studies of around 1 to 1.5%, depending on the particular medication. So if your baseline A1C is much further from goal than that, insulin is going to be the most effective medication at helping to lower the A1C. So if you're looking at the different medication options, maybe you're trying to avoid any gastrointestinal side effects like we see commonly with other medications or other side effects. Maybe you've tried other medications before and they weren't sufficient at lowering glucose. Insulin could be a great option.
Yeah. And I often see insulin used, or let me say the most common 2 times is when someone comes in with very high blood sugars, and we know insulin's going to work quick. Some of the other medicines are pretty effective, but might take a while. And the other time is there are people who, if they've had type 2 diabetes for a long time, they might be on all these other medicines, but their pancreas just isn't keeping up. You can just imagine that pancreas going, ugh, and it's just not pushing out enough insulin, and then you need insulin. And just to round out our discussion, the other class of medicines that we also see used are the DPP-4 inhibitors. They are incredibly well tolerated, which has been their advantage. They're not quite as powerful at lowering blood sugar, but not everyone needs their blood sugar lowered that much. They're very safe. They don't have hypoglycemia or low blood sugars as a side effect. As you mentioned, one of the concerning side effects with sulfonylureas. So I'll often use that class of medicine in our older, frail adults, particularly because they're easily tolerated, they don't have the GI side effects, and they don't have the low blood sugars attached to them, but they don't have all of those other benefits either of the other classes of medicines that we've talked about. Sarah, it really occurs to me that we have covered a lot of ground.
We sure have. There are just so many options within the treatment of type 2 diabetes. And as much as we go through this conversation and it seems like it could make it complicated, I love that there are choices. That just means that if you are looking for a medication that might be a good fit for you, you've got a menu of choices and you have options to choose from. I think that is empowering for many individuals. What are your thoughts, Neil?
I'll tell you, Sarah, I love that you use the word empowering because that's really what our podcast is all about. Listen to the information we provide and then open up that conversation so that you understand what you're taking. You can talk with your clinician and help find the best medicine for you. Sarah, it is always such a pleasure talking with you about diabetes.
It's great talking with you too, Neil. And I'd just like to end with my final thought, which is focused on this empowerment of choice and selection. Sometimes I will start working with a patient who's living with type 2 diabetes and they're on medications that have been around for a while. Maybe they've been on that regimen a really long time. And if it's working and it's meeting all of their goals, then that's fantastic. Stick with it. But if it's not, or if you want to explore these different options that we've talked about tonight, or sometimes you find out you have a different medical condition that might tweak what we would prefer in terms of selection of therapy, I think those are all great opportunities to revisit that conversation and advocate for yourself to say, maybe there's a different option that's better for me now, even if what I was using before was working for me in some ways. What do you think, Neil?
I think those are great points, Sarah. Managing diabetes is always a team effort. And as a patient, you're always the most important part of the team. In fact, in the American Diabetes Association Standards of Care, there's a diagram of all aspects of care, and everyone should know in the center of that diagram is the patient. Don't be afraid to ask questions. Don't be afraid to share preferences, to advocate for the treatment that fits your individual lifestyle and health needs and goals. We've only scratched the surface of all the medication options available today. There is always a lot more to learn. Tune into future episodes as we'll continue to explore the latest evidence and updates to help you make an informed decision about your diabetes care. Thank you for listening today. If you have any thoughts you'd like to share, leave us a voicemail by calling 703-755-7288. Again, that is 703-755-7288. We hope to hear from you. For the American Diabetes Association, I'm Dr. Neil Skolnik, and thanks for listening.